Welcome again, everyone, to Probing the Literature, hosted by ACEP and SAEM. This month, we will be reviewing lung, is what we're going to be going for. This session will have two guests. We're going to be having Dr. Daniel Lichtenstein and Dr. Emmanuel Pavetta, who only live about 8 hours apart from each other by car, which I realized after doing some quick Googling. So we look forward to their presentations. A brief review of the schedule. This is in Eastern Standard Time, so not relevant to everyone, but just an understanding of how the time will work. I'm going to do this brief introduction. Dr. Lichtenstein has a presentation to review related to his 2008 article on the Blue Protocol. We will then have question and answer time after that. Then we will break out into our small group sessions. Well, once you are done your discussions in small group, we will then reconvene for a brief synopsis of what the groups are talking about with Dr. Pavetta. And then mostly that time is just kind of open with the groups, the leaders, but anyone who wants to ask a question to Dr. Pavetta at that time, or even Dr. Lichtenstein if he's able to stick around. And we can just have a group discussion about lung ultrasound, COVID, and shared experiences and shared protocols. After that, it will be about 4:20. So I did not specifically make that time related to any social constructs that might be out there. After that, we will do methods consults for anyone who is interested in discussing possible future articles that they would like to work on, projects that they're currently working on. We encourage everyone to just come. If you have an idea, great. If you want to just listen to how, basically how the sausage is made in academic research, I encourage everyone to stick around. All right, with that, I believe one thing I wanted to review was just vocabulary. Lung ultrasound does have a few vocab words that may not be familiar to everybody. So LUS is just lung ultrasound in general. LUCI is lung ultrasound in the critically ill. The Blue Protocol references bedside lung ultrasound in emergency medicine. And PLAPS is a posterior lateral alveolar or pleural syndrome. Kind of when we go to that last position in the lower area near the diaphragm and we see a bunch of B lines or consolidation, that's kind of the reference there. In the chat, I will be putting up the articles. And without further ado, I'd like to introduce Dr. Daniel Lichtenstein. He's currently the president of the International Training Center in Holistic Ultrasound. He is a medical intensivist in Paris at the Hospital Ambroise de Paris. So without any further delay, I'd like to share Dr. Lichtenstein.
Well, hello. I think hello, everybody. So we will try to share the screen, doing as we did in the training. Great, it seems to work. I hide this thing. I begin to be a professional with Zoom at last. Well, so we have 20 minutes to share. I have my timer, which is a precious tool. Time is our usual tool. Oh, I will make disappear all the images. Voila, top 20 minutes for sharing a small story of the Blue Protocol. I hope the images are working. No, they don't, but I am accustomed. I know what to do. Well, fine, it works. So I have the pleasure to be invited by Daniel Mirsch, who I discover, and it's a great honor, pleasure, privilege to see that this great world begins smaller and smaller. And I will just specify that I have no conflict of interest, and I hope never, I hope. And this is the map of the SURF that is, we succeeded to train 44 countries in a specific spirit. And people who come at SURF come back to their countries with a kind of a role of ambassadors. I'm a bit sorry for my English accent. Maybe one day I will speak perfect English. Do not lose time. We will first see a very small story of the Blue Protocol, just indicating that when I was a student, I discovered in 1983 ultrasound. I was fascinated. I said, wow, he puts the probe in the body and he can see the gallbladder and fluid around. I was just fascinated to the point that I learned the year after I made a period rotation, you call that like this, in a radiology department where I learned a bit of ultrasound. The year after, I began my responsibilities in a critical care with night shifts, imagine. And this is where I made a kind of a transgression. That is, I borrowed the ultrasound machine from the radiology department. There was nobody after midnight. And I did what I could. But, well, of course, each time I touch to this button, I lose the slides. Okay, no panic, I know how to do now. Voila. And our main opportunity was to see the doors of the intensive care unit of hospital Ambroise Paré opening, François Jardin. Great, that was the first intensive care unit or maybe a medical area with critically ill patients with an echocardiographic machine. I was at the best place. SURF has a quiet revendication to have just simply redefined ultrasound, not lung ultrasound, it is just included. And this is the humble contribution of SURF. That is, in one sentence, ultrasound for the critically ill by the critical care physician, whole body ultrasound. That means for the critically ill, things that were not done before, like subclavian cannulation. This is the contribution of SURF in this article, 1991, by the critical care physician, no longer by the radiologist, because we are the first line doctors, I don't insist. And whole body means including the most important, the lung is the most important organ, isn't it true? So our contribution, as you can see, is not the lung, just a different use of critical ultrasound. This lady came in the hospital with a shortness of breath, and although it is of high interest, we will not take time to read the history, the clinical findings. We just see that she needs urgent therapy. We cannot see, is it a COPD or a hemodynamic edema? The echo is not working, no cardiac window, heart hidden by this bloody left lung. Instead of having a beautiful cardiac window, we have this. And the point is to see, but what is this exactly? I see B lines, multiple lung rockets, I see lung sliding, I see no consolidation. That's the B profile of the Blue Protocol. And what we see is that kind of a firework at 4 anterior points, which make the B profile with the priority diagnosis of acute hemodynamic pulmonary edema. We will say hemodynamic edema to spare time. And so you know how to treat once you have the diagnosis. That was, of course, a hemodynamic edema. In this example, lung ultrasound, Lucy, proved to be superior to expert Doppler echocardiography, which was not feasible. There was no window. So we have taken a decision to focus as long as necessary, years, decades, I don't know, on one application of the Blue Protocol, what we have seen, the B profile, usually associated with hemodynamic edema. And we will see how we do a Blue Protocol. And what is first the Blue Protocol? We can say that the Blue Protocol is a fast protocol. Why? Because it takes 3 minutes at worst, 5 seconds sometimes, devoted to the patient in acute respiratory failure, considering the lung, because we are logical, the patient comes for a lung suffering, so we study the lung. The veins are completely part of the blue protocol when we suspect embolism, and the blue protocol respectfully considers also the heart, just to tell that the heart can be deeply simplified. And look, the example that we took, we did not use the echocardiographic findings, and there is no heart in the decision tree of the blue protocol. Here it is written. We will just, so this decision tree is available. We will just detail the timing, duration of the blue protocol, and we will imagine the longest variant when everything is normal anteriorly, when the venous network is normal, and when there is no PLAPS, as Daniel defined previously. The diagnosis is the nude profile, which indicates usually exacerbated COPD or acute asthma. This takes 3 minutes. So we begin by scanning the anterior lung, and we will see the 4 blue points later. It takes less than 1 minute. If we are lucky, we scan the correct area and we see one of these 5 profiles. This anterior wall analysis that we call the fast track blue protocol is sufficient in half of cases. That is a very fast protocol. If everything is normal, that is when we have the A profile, we look at the veins in a specific protocol that is unfortunately not published. It's impossible to publish nowadays. If we see the DVT at the first apply, it costs, so 1 minute of anterior lung plus a few seconds. If not, we have to make our protocol at the venous network that is specific, that takes 2 minutes. If the venous network is negative, we come back to the lung, to the posterior lung. This step can last a few seconds if we see a PLAPS, or if no PLAPS is visible, less than 1 minute. And you can see at the right the 8 profiles of the blue protocol. The last one is the nude profile that we all have when we are normal, but when we are dyspneic, it is related with COPD asthma. So we will insist on the B profile because I see that it is highly necessary. So let us see carefully one major impact of the blue protocol. Look, we have an anterior approach, fast-tracked blue protocol, a probe that you will see is universal at the whole body, a simple equipment. We don't use Doppler, and we don't have Doppler in our Hitachi 405, that is discontinued since many years. And let us see. At the anterior wall, these are 2 patients. Left and right, we see lung rockets. To the left, we can see a beautiful lung sliding. To the right, lung sliding is abolished. The difference is caricatural. To the left, we have the B profile, likely hemodynamic edema. To the right, this is the B prime profile, which is usually linked with pneumonia ARDS. I put those together for saving time. And now, to the left, we can see only lung rockets, which are moving, B profile, hemodynamic edema, likely. To the right, we can see anterior consolidations with the surrounding B lines. We cannot call this a B profile. This is a C profile because of these even very small consolidations. And this patient to the right has usually pneumonia ARDS. We have to see now the problems with the native articles. So we were given 5 minutes and we will make some updates. So our great problem is the time, even by publishing our articles. And our long, eternal is not the good word, our ever problem since 1990 is succeeded to publish. And today, the problem of publishing has worsened. I'm very happy. And ironically, the honor that I have today with you all, due to the few articles that I succeeded to publish previously, generates a lot of work. Therefore, it is impossible to publish any updates. No time, or when we have time, rejected. Where is the mistake? So we try to express in our solicited articles, but to publish an original article, it's so difficult. So what did we change in the decision tree? There are very small changes. We specify to the left, not pulmonary edema, this is meaningless, but hemodynamic edema. And to the right, we have replaced, it was written A lines, and now we specify A prime profile. This is one slide of the SURF. And look at the right, the A prime profile is the anterior combination of lung sliding absent, lung rockets absent. The A prime profile is the profile fully sensitive, 100%, to pneumothorax. The videos are in our website. Do we need an update regarding the current pandemics? I would say no. The current pandemics was written in 2008, and we will see again, or discover for the youngest of us, the C profile. This is a C profile. That means anterior lung consolidation. Regardless the number, regardless the volume, this is a fine consolidation, centimetric. It can be very small. It can be the CM line that is millimetric. If we see lung rockets anterior, but also consolidation, we cannot call it the B profile. This is a C profile, which indicates almost always pneumonia. So again, the previous slide shows a striking difference between the left, where I see zero consolidation, and the right, where I see very small but very consolidations. C profile, pneumonia, IRDS. An update is about the blue points, which is a nice proof that publishing is impossible, but when you succeed, it can be useless. So this article, I need to make it better known. So this is the image of the 4 zone that you can see in the International Consensus Conference, which we do not use. We use the blue points. That is, look at the zone 1 of the Consensus Conference. This is where we stop the lung analysis, because below we have the abdomen. And as they did for electrocardiogram, we define 4 anterior points, 2 per lung, the upper blue point, the lower blue point. No time for specifying in more details. When you take the lower blue point and you put your probe laterally in a transversal aspect, you have, as far as you can go in a ventilated patient, the PLAPS point. The probe is short. It is a good point for going as posterior as you can. PLAPS, posterolateral alveolar and or pleural syndrome. It looks to the youngest very cranial, but no, the lung is not so big. It does not come to the feet. The PLAPS point is always a bit above the diaphragm, which is in this image at the arrow, either a lot or a little. A lot, I mean 1 space, 2 spaces, not more. Well, The blue hands are universal regardless the size of the patient. A lung has the anterior size of 2 hands, period. It works on the human, not in the bats. I look at the timing, the future of the blue protocol. We have 3 minutes. The future that we wish at SURF. So 3 minutes, 3 wishes. We would love to see first, wish, the community trying just once to try the machine that we have defined for making critical ultrasound with 7 criteria. These 7 criteria, we will just, for critical and lung ultrasound, we have time to detail only one, the criterion number 2, which is the probe. And we are proud to make whole body ultrasound with one unique probe since 1989 with the 1978 machine, where the revolution of today's could have been possible. And we currently use our Hitachi, which is no longer built, since 1992. The universal probe in 2 slides. The ergonomics, the critical range, is exactly what we need for transfontanelar approach. And they made a microconvex probe for this. So look, there is a narrow window initially, there is a large organ to scan, and a precious organ, which is the brain. So you need the resolution. The baby's brain are large. This is exactly the requirements that we need. And look, we can see the lung. This is a very diseased lung, C profile. We can see the heart, beautiful contractility, no tamponade, etc. And in second, in the blue protocol, the venous system, where you can see a beautiful jugular thrombosis. One probe suits for the whole body and has the best ergonomy. The future, a second wish, we would like to see a decrease of the number of arterial blood gas. This is painful. Look at what it can give as disorders. And if we can decrease by making blue protocol 1% in 1 decade, it would mean no more blood gas in 3021, or even sooner if we all do the same. And the last wish is to decrease the medical radiation, that is the Lucy FLR project. For knowing more, there is all the opinion articles that we can write. Our book is available, and we have, not today because of the restriction in the flights, but our Parisian surf, which still lives. In conclusion, for staying on the timing, we would love to make our past, which is also our present, your future, and you should just try it once and make your opinion. The motto of SURF is tomorrow's medicine with the tools of ever. I have a microconvex probe with me here, with a pocket machine that I use for my medical transportations. This is my scientific family. And we are a bit ahead of the 20 minutes. Thank you very much for your attention.
Thank you so much, Dr. Lichtenstein. It's an absolute pleasure to go through that history and kind of like where it came from to where we are. So I'm going to open up the floor to everyone who has questions, comments, or thoughts.
Oh, I'll jump in first. You know,
my English is a bit poor. If you go a bit slow, I will understand every word.
We'll all be better served with your English than my French. So fair enough. The probe question, because having looked back, our microconvex is not particularly popular in the United States, and I don't think I've ever used one in my training. What we will tend to do is develop a personal preference of a high frequency linear or a curvilinear low frequency or a low frequency phased array and just get trained that way and use that one for the lungs from then on. And we'll switch between probes. And so I'm curious if you've had any experience comparing the micro convex that you've developed this with some of these other alternative probes that we are being sold.
Well, thank you. Well, the microconvex probe is not popular in the United States, but it will, soon or late, it will. Meanwhile, I prevent nobody to use the 3 usual probes, but I just give one example, a very simple example. A young patient dies. He is hot, cardiac arrest. You take him out of the automobile, for instance. You have to take a probe, you have to change the probes. And what you do for this cardiac arrest, you will do that also 20, 30 times in your daily life. You use ultrasound for each patient that you will see. So it will take a huge time, a huge cost, but I prevent nobody to do this. I just describe how I scan a patient. I cannot tell more. I think that the world experts, who are numerous today, should at least once ask to the manufacturer, please, I would like to test a microconvex, which must be holistic, by the way. There is a requirement, ergonomy, but also resolution, range. And we will talk of it after, I'm sure. Oh, did I answer your question? You are Andrew Shannon from Florida.
Yes, yes, thank you.
Mike Lynn has a chat question. What manufacturer is the one that you use?
Oh, thank you. That's a nice question. There are many brands. The wonderful Hitachi did not understand what is the revolution of the clinical ultrasound. They did not care. And I spoke to Kamani, the CEO of Hitachi Medicals, but it did not work. So what I use currently, each time there is a ground in my hospital, I use a Draminski machine. That is a Polish machine, which Draminski, the Opus D, which has the 7 criteria that I highly require from a machine. Draminski, I know that nobody knows this machine, but just keep it in your mind. And in my intensive care unit, we have, I still have my Hitachi 405. This is my basic machine that I use every day, but I need to speak of something that is done today, and I use it from time to time. Also, we have plenty of General Electric in our intensive care unit, and we have the Vivid. So the Vivid GE are not too bad, I must admit. They can do a nice work, but when you want to see a pleural line in a skinny patient, the fast array technology will build artificial millimetric consolidations. Or let us say, you will not be able to say this is a normal pleural line, or there are several very small consolidations. This is one example where you will, I will say it differently. If we use the cardiac probe of a very good machine, there will always be a moment where we will feel limited. And the shape of the microconvex probe is more ergonomic than the one of a cardiac probe. So I can be very talkative. The machine that I found the most amazing is Philips, not the CX50, but the Epic with a microconvex probe, I was fascinated by the image quality, but the machine is very big, plenty of buttons, very expensive, takes time for switching on, so it does not have all the requirements. This is a long talk. I don't want to take all the time for these things because it deserves not a webinar, but something very quiet. And we should speak of the 7 criteria, one after the other. I will just say one thing. You will not like it. When you take this tool, this is a ruler, you will see that the laptop revolution is only a commercial revolution, because my Hitachi or even the ADR 4000 of the years 1978 are not larger than the laptops of today, which are on their cart, because the dimensions that create the problem in the hospital are the lateral obstacles, and the width makes the importance, not the height, because the height laptops are very narrow, but not in this dimension. A child will see that immediately, and I insist that a laptop is not mandatory in a hospital if we have a more narrow machine. And there are 6 other criteria, the probe and 5 others.
Very good. Thank you very much for answering those questions. I'm going to open up the breakout rooms at this point for the second article for Dr. Poveda. If anyone has any questions or concerns about their group, feel free to come back out into the main room and talk to me, and I will adjust things from there. Thank you very much, Dr. Lichtenstein. If you can stick around, we'd love to hear from you again near the end or during the breakout sessions. Otherwise, I will see you guys in about 20 minutes.